Everybody, and welcome to this week's Gastro Echo session, which is hosted by the Gastro Foundation in association with Project Echo from the University of New Mexico. These sessions are held on a weekly basis on a Wednesday afternoon at 4:30, and we have a variety of topics. Today, Prof Martin Hale and myself will be taking us through a few histological cases of alcohol-induced hepatitis. We will be taking, the chat will be open questions, so please feel free to include those as we go. I'd like to then introduce Professor Hale in order to take over, and he will be presenting on the SALVE criterions, which is a consensus document on histological grading of severity of alcoholic-induced hepatitis. Thanks, Prof.
Thanks, Bilal. So, Cheryl, I'm not sure. Do you want to run the presentation from your side, or shall I do it from my side?
I can do it for you, Prof.
Okay, that's fine. Thanks. Okay, so if we could just go to full screen there. All right, so good afternoon, everyone, and thanks for joining us. And we thought that this particular afternoon we would take a slightly different view of alcohol-related liver disease. And here we're going to look at the SALVE classification for alcohol-related liver disease. Now, you may, who don't know what SALVE is, it's the study for the association of liver disease in Europe. And this has come out of the basically out of the EASL group in Europe, and it provides or it's an attempt to provide some sort of prognostic information with respect to patients when they present with liver disease. It is entirely based on histopathology, so it's a histopathology-based set of criteria. And I've tried using it myself, and it is tricky. I'll take you through the sort of the nuts and bolts of the various criteria in a short presentation, and I think there are some difficulties in interpretation, and those of you who are histopathologists will I think readily see the problems that we potentially would experience. Having said that, though, I think that it is an attempt to give some sort of prognostic information. So, first slide, then, please, Cheryl. So, as I said, that's the group. It's a comprehensive group from a number of countries. The patients that were enrolled in this particular study numbered just over 400. I think it was 445, if I remember correctly. And this was done during the course of the pandemic. And in fact, a lot of these images were all scanned images. And I think therein also lies a potential problem because of the poorer resolution of scanned images compared to glass. Having said that, I do recognize that there's certainly some very high-tech and high-resolution screens that are available together with scanning instruments. So that may not necessarily have been a problem. But certainly I find that just using our own scanned equipment and comparison with glass, that there sometimes is a difficulty and a discrepancy between the interpretation, particularly when one is looking at some of the finer details. As you can see, it was, so those of you who want to see, look at the article. I would suggest you download it and read through it after the meeting if you're still interested. And I would certainly urge you in your future reporting, in fact, to start to incorporate these criteria. So it's from the Journal of Hepatology in 2021, and the reference is there. Next slide, please, Cheryl. Right, so I always like simplicity personally. I think that the more complex classifications become, I think they're very difficult to interpret, and they're also difficult to allocate to specific bodies. And from my own experience, I certainly like the Brunt classification system as I do the Metaver systems. I think that they are both very good and, in my view, sort of reproducible classification systems. But the problem with both of those is that they don't really give histological prognostic parameters, whereas this does. And I'll take you through these. So the first is steatosis. And those of you'll readily recognize that, in fact, the degree of steatosis, and this will be macrovesicular. And in fact, I think this is also a particular discrepancy, because they talk about macrovesicular steatosis, which I think is an old term, and I certainly wouldn't suggest that you use the term macrovesicular steatosis. I think it's fine. We all understand what macrovesicular steatosis means, whether we're practicing histopathology, whether we're surgeons or physicians or pediatricians. The problem comes when we talk about microvesicular steatosis. So I think it's far better, as I've said in previous discussions, to use the terms small droplet and large droplet, where large droplet steatosis is macrovesicular steatosis. So large droplet steatosis, then we assess the parenchymal involvement and divide that as to whether it's 5% or less than 5%, 5 to 33, 34 to 66, and above 66. And I think that that's relatively easy. I think we can all do that with a relative degree of conformity. The next thing is to look at and is to assess the extent of the hepatocellular injury. And that is done, we call, that's in the article, the activity grade. And that is divided into two broad categories. The first is the hepatocellular injury, which I think in its own is okay, and I think it's also difficult to, at least it's important to separate that from lobular neutrophils, which is what you see here. So hepatocellular injury, as it were, is the identification of Mallory-Denk bodies or ballooning degeneration of hepatocytes. And that's divided basically into three different groups. Very easy to reproduce, none, few, or many. I think sometimes whilst it's important, I think, to not have three groups, in other words, 1, 2, and 3, I think can be difficult to decide whether you've got few neutrophils or many neutrophils. And the guideline that's given in the article is that many neutrophils basically equates to easily recognizable. Sorry, not to neutrophils, I'm talking, well, the same thing, Mallory-Denk bodies, many Mallory-Denk bodies or ballooning degeneration. In other words, it's readily identifiable. And then the same discussion and separation is allocated to the number of neutrophils that are present in the lobules, whether they're absent, whether they're few, or whether they're readily recognized. Satellitosis refers to the peripheral cuffing of ballooned hepatocytes by neutrophils. And then cholestasis, which is important. And here, in fact, it was divided into whether there was canalicular cholestasis or ductular cholestasis. And in this particular instance, in fact, it was decided, in fact, that although cholestasis was divided into these two categories, in the end, it didn't really matter. The important thing was to identify whether there was cholestasis or not. And then what happens is that you then create a grade. I'm not sure if you can see it because of the bottom of the screen. But effectively what you do, can everybody, that's it, that's better. So you can see there, if I don't take my arrow away, that steatosis is given a score of 0 to 3, and hepatocellular injury, in other words, ballooning or Mallory-Denk bodies, is given a score of 0 to 2, in other words, 0, 1, or 2. You add that together with lobular neutrophils, also scored 1 to 2, and then cholestasis, whether it's canalicular or ductal, is given a score of a binary score, in other words, either absent or present, and that would be 0 or 1. So let's move on then, please, Cheryl, the next one. And then there is the fibrosis score. And this is a useful picture. I'm sorry it's a little bit cramped, but it is useful to be able to see that, particularly for the histopathologist, because it does give one a pictorial reference to look at. And I guess it would be the sort of thing that you would keep in your sort of ready reference, which is usually next to our microscope in a file, or potentially on a wall, usually in a file. And then we can see, for example, do a comparison. And this looks as though it doesn't actually say what stains they used, but I suspect it's probably a serious red. And you can see the degree of fibrosis. So this would be SFS, which is SALVE fibrosis score, SFS. So this would be a score 1. And this would be a score 2, where there's a bit more portal fibrosis and a bit of perivenular fibrosis. And those of you who use the Brunt score, this would be equivalent to stage 1. Then you have 3, which basically includes extensions. Sorry, I just stopped for a while. My internet's unstable. Okay, back. See the expansion of the fibrosis, and now we're starting to see bridging, and there's more type fibrosis. Then this would be the next one is stage 4. And in fact, people are now starting, and you will have seen in the literature about grading cirrhosis. In other words, in the old days, we would say that, and I must say I'm guilty of this myself, whereas I still talk about cirrhosis as being end stage. But these days, with the concept of reversible fibrosis becoming more evident, reversible cirrhosis becoming more evident, is probably becoming important for us as histopathologists, in fact, to separate out cirrhosis into 3 different elements. The first is where the septi around the cirrhotic nodules are thin. The next one is, so that would be a 4A. Then there's a 4B, where there is a thickening of the septi into broader bands. And then there's that would be 4B. And then there's 4C, where they're really broad bands of fibrosis. And I think this is really where a lot of this sort of interpretation comes in, because you often see quite considerable variation during the length of, whilst one is examining the length of a biopsy. Next one, please, Cheryl. Right, so then this is why it's important, and this is the effect of that grading system. In other words, the activity on survival. And here you can see the survival curves. And for example, this is if there is low-grade activity, where it scores 0 to 1. And you can see that there's a 10-year survival probably of just below 75%. Whereas if you have a higher grade of activity, grades 2 to 4, then the survival drops off quite significantly to below 50% at 10 years. Now, the other thing, and I always remember the late Professor Mike Q, because he would come out to have meetings with us on a regular basis every Monday afternoon, Monday lunchtime at Barrow. We had a weekly adult liver meeting, and we would go through the various cases. And we would often see patients with alcohol-related liver disease. And he would always say that the minute, if a patient has cholestasis, that is a bad prognostic sign. And I hope you can see this. Let me just change this, change it maybe to that. There we are. So here you can see, for example, that the presence of cholestasis, and this is, excuse me, this is both canalicular cholestasis and ductal cholestasis. And you can see that there's very little difference in the survival curves as to whether it's ductal or canalicular. So effectively, the message, take-home message there is that if you have cholestasis, then that is of a poor prognostic sign. One of the articles, at least the article does not mention, is the presence of intracellular cholestasis, intracytoplasmic cholestasis. And there, I think certainly when Prof Q's interpretation of intracellular cholestasis was they also carried a poor prognostic criteria. Admittedly, the clinical situation was a little bit different in that many of those patients, in fact, had acute alcohol hepatitis, and that they had been binge drinking, for example, at the weekend. So those are the survival curves. Next, that's for activity. Next slide, please. So this then is the last slide, and this really just relates the survival to the degree of fibrosis. And you can see that if there's no fibrosis, there's 100% survival. And then if you have broad bands of fibrosis, that survival drops all the way down to a 10-year survival around about 32%. Now, what we don't have in this particular article and what the SALVE criteria don't address is the marrying of the grade and the stage. And certainly, Bilal, Chris, would be interested in your thoughts on, and you guys have been to the EASL meeting recently and will have heard discussion on that. So I'm not sure how one marries these two. For example, do you take the worst prognostic grade? When I say grade, the worst prognostic criterion, I should say, the activity, or do you take the fibrosis score? Which one trumps the other? Interesting point. All right, so now what I've got is I've got 4 cases, and I thought that each of them has got an alcohol history, and I thought that we would go through them. So, Bilal, over to you. First patient is, as we
Miss MG.
MG, yeah.
So Miss MG is an interesting lady in that she initially presented to our hepatobiliary surgeons with a pancreatic malignancy, an adenocarcinoma, and she underwent a Whipple's that was successful 6 years back. There was a suspicion of recurrence that has never been 100% proven. But she was placed back onto chemotherapy, and she received capecitabine as well as oxaliplatin in that process. As time has progressed, her liver has been noted to be looking somewhat more ragged with the development of portal hypertension. Now, oxaliplatin is a drug that can certainly result in this, and we were worried about possible chemotherapy-associated steatohepatitis as a further differential. She had initially denied much alcohol intake, but as the week went on, she reported a bit more than we were expecting, and this was very much analogous to what the liver biopsy showed.
Thanks, Bilal. So what I'm going to do now is share my screen, and this is the biopsy, and you can see that that we've got extensive steatosis, large droplet steatosis. Sorry, I'm taking photographs here. So we've got this extensive large droplet steatosis. Just focus that a bit more. And that's throughout the biopsy. And if we were to score this, and if you've got a pen and paper, you can sort of write it down next to you, and just under low power examination, I gave this, I felt that there was basically 34 to 66%, about 2/3 of this liver showed large droplet steatosis. So I gave that a score of 2. And then when we go through this, we can see that, and now we go to look for activity. And activity is in the form of Mallory-Denk bodies or ballooning degeneration. That's the one criterion, and or both. And then the other one, second criterion, is the presence of neutrophils. Now, ballooning degeneration, I think, is difficult to see. It is there. So, for example, I think there's a bit of ballooning here. So I think that's a bit of ballooning degeneration here. So it's going under low power. So I think this is a little bit of ballooning here and there. So it is identifiable. And I think there is more ballooning. I've just got to tie this up. I think this is more ballooning here as well. So the question is, do you call this a few or many? And I think probably would call the ballooning degeneration few. There's certainly not many. And that's what's good about dividing classifications into more of a binary, using a binary system rather than a 1, 2, 3. Because as humans, we always take the easy route out, and we'll say, well, this is 2, and that really doesn't help anybody. And I think there's probably a bit of ballooning maybe down here as well. So I'm happy with ballooning. I don't know, Janet, I think you're on the meeting. Don't know what you would agree with that. I've lost that cell there. So let's see now if we can find Mallory-Denk bodies. Mallory-Denk bodies, I couldn't really find. So I wasn't convinced about Mallory-Denk bodies. So then the next one, so that would be for the activity, going back to if you've got that that score. So ballooning would be 1, and then the Mallory-Denk bodies would basically not seeing any, so that would be 0. But that's all part of the hepatocellular injury. And the next one is to look for the neutrophils. And the neutrophils, I think we can see relatively easily. There are, in fact, quite a few neutrophils in this. Whoops, going too high. So these are all neutrophils. Some of these are neutrophils. Clusters of neutrophils here. These are neutrophils. And one could even suggest, for example, around here, that there might be an element of satellitosis. So neutrophils, I gave this a score of 2. In other words, I didn't have any trouble finding neutrophils. Didn't have to search for them. So that gives an activity score of 3. In other words, 2 for lobular neutrophils, because there are many. Remember, the score there is 0, 1, and 2. And then for Mallory-Denk bodies and ballooning, it's the same, 0, 1, or 2. So I gave that a 1. So the activity score there is 3, the total score, because you add the 2 together. Then when we look at the fibrosis, and if you look at the fibrosis, it's difficult really to be absolutely sure, and you shouldn't really use the H&E to assess the extent of the fibrosis. But if we look at the mass on trichrome, you can see that the fibrous tissue becomes readily apparent. It's a little bit dark, I'm afraid, but you can see this sort of fibrosis there. And in fact, I gave this a score of 1. So there's a bit of portal fibrosis. Bit of portal fibrosis, for example, there, an expanded portal tract. And then you've got a little bit of fibrosis in this area here as well, with a little bit of extension into the parenchyma. So I gave that a score of 1. So then this would then be on the SALVE score, it would be an activity grade or grade of 3 and an SFS score of 1. So going back to those graphs, then Cheryl, perhaps you could just put that up for me, please, again. In fact, what I'll do is I'll see if I can get mine up too, and then that'll be easier. Yes. Okay, Cheryl, I've got it up so I can
What would you need?
I'm just going to show the presentation again. That's fine. I can go through it. I've got it up. Some discussion on that one. So what I'll do now is I'm just going to go back to the presentation. And everybody see that?
Yes, Prof.
Can you see it? But can you see the screen?
Yep, we can. We can see the
Yes.
screen.
So, okay, so we gave the score, the steatosis grade. We said that was 66%, I think, did we not? No, we said it was 0 to 66%. And then we said that there was not much in the way of Mallory-Denk bodies, so we gave that a 1, but we felt that there were lots of neutrophils, many and or satellitosis. So that's quite good because I think that that's reproducible. So that gives an activity grade then of 3. And then there was no cholestasis that was evident. And then as far as the fibrosis is concerned, I hope it's changing. Is it changing with you?
Yes, it is.
Okay. So as far as the fibrosis score is concerned, we gave that, we felt it looked a bit like this, which is a score 1. We didn't have fibrosis there, which would be, sorry, we felt it was this here, sorry, not this one. Hang on, I'm getting mixed up. We felt it was this one here, where there was mild portal fibrosis and not much in the way of linking. All right, so let's go to the next one then. Any questions at all on that? All right, Bilal, let's move.
Prof.
Yeah.
Yeah, just in terms of then prognosticating here, what they showed was it's a composite score between the degree of activity, the degree of cholestasis, and the degree of fibrosis. They don't necessarily all clump into one specific score, but they do. If you've got cholestasis, that's a poor prognosticator. If you've got advanced fibrosis, that's also a poor prognosticator. And if you've got a very severe hepatitis, even in the absence of advanced fibrosis, it can also be a poor prognosticator. So those are the three factors that they looked at in terms of prognosis. So yeah.
Yeah, and also I'll see you, Chris, and the other thing that is also mentioned in that article as well is if patients are decompensated and they have cholestasis, that also imparts a poorer prognosis as compared to patients who are not decompensated. Chris?
So Bilal, I mean, and Martin, I mean, are they all weighted equally? I mean, ultimately, it is fibrosis really that determines portal hypertension, hypersplenism, esophageal varices, liver decompensation, hepatic encephalopathy. So clearly, I mean, that must be the major determining factor. I mean, Martin's point initially was, is it the cellular activity that's important, or is it the ultimate fibrosis? It's cellular activity which all contribute towards fibrosis. And also the type of fibrosis is also not equal. There's soft collagen and hard collagen, depending on the etiological agent, number one, and the site of deposition, whether it's portal or centrilobular. So there are a couple of nuances that make this very interesting topic of, is cirrhosis reversible, which we all acknowledge now it is, but the etiology, the type of collagen, and the site of deposition might all affect prognosis and reversibility.
Yeah, you're absolutely right, Chris.
There's an amazing lecture that Massimo Pinzani gave at the last EASL. It is actually one of the best lectures I've ever heard, and I think we should invite him. I mean, he's, you know, it's all on fibrosis and type, and I think perhaps we should consider inviting him on one of these sessions once, because it's so illuminating and so.
That would be great.
Now, you know, it's just the concepts are so new now, and you know, that it's just so exciting to hear.
So specifically, they do talk about cirrhosis with broad septa being particularly poor prognosticator. So you know that sort of chicken wire that we often see, that appears to be certainly almost dissolvable collagen, which can improve. And then I think in terms of the cholestasis, you really are talking about cellular function, not just the inflammatory grade per se, but I'm sure as your inflammatory grade increases, probably a degree of your nutritional state, and when you have this cholestasis where your liver is no longer clearing the bile, that being a further poor prognosticator.
Yeah.
Almost a functional assessment.
Yes, and what they don't pick up on intracellular cholestasis, which we do seem to see from time to time. Sometimes we see it with canalicular cholestasis, but it's very seldom that one actually gets ductular cholestasis.
We are running somewhat out of time. We've only got 20 minutes left.
Yeah. Let's move on to the next one.
I know there's another 3 more cases.
Yeah.
The next
SG.
young lady, Miss SG, is a 41-year-old female with this time very little guesswork needed. She admitted to quite excessive drinking. Interestingly enough, her INR was 1.2 on admission and a MADRI score of only 10, with a MEL sodium score of 13. We used both of these to determine whether or not we would be treating with steroid therapy, and she did not qualify for that, so we focused more on nutrition and psychological therapies with her.
Right, thanks, Bilal. So now this is interesting, and what I didn't mention when I was talking earlier is that in fact steatosis, the degree of steatosis, does not have any prognostic significance. Okay, so it's only whether there is hepatocellular injury or not. So even if you've got 100% steatosis, large droplet steatosis, it does not affect the outcome. So that's I think an important point. And we've seen that. So for example, let's have a look at this one. So in this particular one here, you can see that the degree of steatosis in this particular patient is much less. And the score that I gave this was a 1. In other words, basically a third of the liver showed large droplet steatosis. Sometimes, you know, I mean, I said earlier at our lunchtime meeting that, we always have to remember that histopath is very much, impression-based, and what we see and what we interpret today, we may not reach the same conclusions tomorrow because of our variable interpretation. We have, for example, unwritten rules. You don't diagnose a melanoma or melanocytic lesion on a Friday afternoon because you can easily miss things or you can overcall. And of course, same thing with later in the day. You want to get away, you're tired, and the rules that apply to pilots, for example, about flying, haven't yet made their way into medicine, and certainly not into the interpretation of histopathological diagnoses. So there's not much in the way of I'll rephrase that. There's significant steatosis here, but there are broad areas where there's not much in the way of fat. So I gave this a score of 1, but in fact, even now, looking at it, maybe this is a 2, and difficult to be certain. But it doesn't really matter because in the overall scheme of things, because the grade and extent of steatosis doesn't affect prognosis. Right, so now let's look at the activity. So the first is you're looking for Mallory-Denk bodies or ballooning or both. And when we go down and have a look at this, we can see straight away that we can see Mallory-Denk bodies. And there we are. I mean, I haven't had to move very far. And there's the first Mallory-Denk body. So there's a Mallory-Denk body there, these eosinophilic inclusions. And one has no in finding. There's another one there, for example. I think there's probably one there. And there is another one down here. Those looks as though those are red cells, I think. But certainly, Mallory-Denk bodies are easy to find. So that means that automatically we're giving this a score now of a higher score. And then when we look for ballooning degeneration, because remember, it's Mallory-Denk bodies or ballooning. Okay, it doesn't have to be both. Mallory-Denk bodies or ballooning. And you can see that ballooning degeneration is also relatively easy to find. For example, that's ballooning there. And then we've got, there are 2 or 3 cells. Look at all that ballooning. There's at least 4 hepatocytes, one up in the corner there, one here, one there, and some more there. So ballooning degeneration is 2, okay? And then when we look for the neutrophils, we can see that there are lots and lots of neutrophils. Plenty of neutrophils here. Okay, look at all these neutrophils, lots of them. So that's a 2. You don't have to search for these at all. So that means that the activity score here is a 4. And then when we go to the fibrosis, we can see the fibrosis. And you can see all the green. All the green. Now the question is, and this is really where the interpretation comes, is this cirrhotic or not? And some of us would probably say, yes, she is cirrhotic. Others would say, no, not cirrhotic. I think we would all agree that there is architectural distortion here. But I'm not convinced personally that this is cirrhosis. So if we look here, for example, I'd like you to take a photograph of this pericellular fibrosis. You've got this broad band of fibrous tissue in the collagen. And then what I'm going to do is I'm just going to pick up the presentation, if I can find it. There it is. So this then is the presentation. And where is it? There it is there. So the question is, what is this fibrosis? So is it this here? Because we've also got this pericellular chicken wire type fibrosis there. I certainly think we've got this, but do we have this? And I think the answer to that is no. So my feeling is that this is a SFS3 score, where you've got this bridging fibrosis and this chicken wire fibrosis. I don't think it's cirrhotic. So here the score would be activity score of 4 and a fibrotic score of 3. So she's, if from a prognostic point of view, has a poorer prognosis than the first patient that we showed you. Bilal, over to you.
Yeah, Prof. And I think that it's not just what's going on in her liver that is giving her poor prognosis. She's got quite significant psychiatric pathology in the background that's further compromising her care. She refused an admission to a rehabilitation facility and hasn't really followed up much in terms of psychology appointments either. So still quite young, but already quite established liver disease, and I am fearful that she's not going to be able to abstain.
Yeah, I hear you, Bilal. But I think still the evidence, I mean, as you've alluded to, I think that even aside from her neurological or psychiatric problems, her liver disease is more extensive than the first patient I showed you.
Yeah. Prof, I'm not sure. Are we, do we have, yeah, we do have time.
No, I think I can get
I'm
through
not,
the other two. Have you got the history for the third
you
one?
happy?
I can, yeah.
I do. So this is a lady that caused us, again, not, we didn't, I don't think we got an initial clear-cut alcohol history. At least it was denied. It was denied to start with. She does have features of the metabolic syndrome in that she's a type 2 diabetic. HbA1c was at 7%. Extensive family history of diabetes. There's further. She was previously hypertensive. Seems that coronary artery disease, hypertension are very much within the family. We were thinking along the lines of a non-alcoholic steatohepatitis, but I believe, Prof, you found further evidence.
Yeah. So this is her biopsy here. And so the history here was also that yeah, so what we've got here is this extensive steatosis, as you can see there. And the steatosis I felt was in excess of 66%, so this would be a score of 3. And then when we look at the activity with things such as neutrophils and Mallory-Denk bodies, let's start again, Mallory-Denk bodies and ballooning, that's the first category. Once again, we have trouble finding ballooning. So I think this is a bit of ballooning here. I think there's probably more ballooning here. Mallory-Denk bodies, we couldn't see. and lobular neutrophils are present, but you've got to look for them. So there we are, right on the end of the biopsy. So there's a focus of neutrophil inflammation, steatohepatitis, which is neutrophil mediated. So that would score a 1. Okay, so now we've got an activity score then of 2. Okay. And then when we look at the Masson trichrome, I think, so before I do that, just show you the impression that one has. And this therein also lies a problem, because when you have cirrhotic livers, often the biopsies fall apart as this is done, because they fall apart along the lines of fibrosis. But if you see here, for example, probably can't see it on the screen, but you've got fibrous connective tissue here, and you've got more fibrosis there. I won't waste your time. I'll go straight to the Masson, or the serious thread to get better contrast. But you can see straight out away under low power the nodular change that we've got in this biopsy. And I think it's probably best evident, for example, there, and also along here. And then if we stop that, so this then would score, because she's cirrhotic and we've got these thin bands of fibrous tissue, that falls then into the 4A category. So it falls into this category here. Okay. So then she's got a score, an activity score of 2, but a fibrosis score of 4. And in fact, I think she's probably a combination of ASH-NASH. And it looks as though she's probably, in fact, most of her disease is actually NASH or metabolic associated steatohepatitis, with alcohol playing a small part. Okay.
Yeah, I think that was our clinical suspicion. And I think it's important to point out that patients with NASH, the synergy between alcohol and the metabolic component is significant and raises your hazard ratio quite significantly. So patients, you know, the teaching was that NASH cirrhotics should not drink. Now it's more anyone with NASH shouldn't be drinking to avert progression of disease.
Yeah. Okay. And then the last patient, below, in the last couple of minutes, we're doing well.
Yeah, just calling up our notes.
This is NM.
Yeah. Sorry, I'm sorry, I have posted the link to the article for this this paper on the chat. I believe it is free to download, so
Yes.
go ahead and do that. Ah, dear.
And certainly if you're
Prof, I don't actually have this final gentleman's
okay.
clinical details.
Right, that's fine. So I can give them to you. So he was 50 and he presented with clinical symptoms of cirrhosis thought to be secondary to either alcohol-induced liver disease or autoimmune hepatitis. He had a strong history of ethanol consumption. There was no portal hypertension. Sorry, he had portal hypertension with ascites, and he presented with acute on chronic liver failure and the hepatorenal syndrome. Was on hemodialysis, and a transjugular biopsy was done. Okay, so 50 years old then, thought to be either to have cirrhosis secondary either to alcohol or autoimmune hepatitis. Right, so let's share the screen. And here you've got multiple cores, and this is really a wonderful biopsy for a transjugular biopsy. We're often not as lucky as this. I mean, this looks like just a straightforward percutaneous biopsy. And I must just say that, and I would just like to pay particular compliment to the radiology team here at Donald Gordon, because you guys do really wonderful biopsies, and without this, we just wouldn't be able to do what we do. So thanks, Charles, and your team. So here you've got, you can see straight away that you've got these broad bands of fibrosis. That's a big warning sign. So let's go down and have a look. So there's the fat, as you can see there, and the amount of fat in this liver biopsy is minimal. So you can see here that the steatosis score for large droplet component is minimal. In fact, it's present, but it's a 1. So now let's look at the activity. We're looking for Mallory-Denk bodies and we're looking for neutrophils. And then when you go down and we have a look, you can see that you've got both components literally in the first field that we come to. So here, for example, absolutely no problems in finding them. So there you've got 3 hepatocytes, 1, 2, in fact 4, 3, 4. We've got 4 cells straight away with Mallory-Denk bodies, these big eosinophilic rope-like inclusions, and you can see the neutrophils as well. So plenty of neutrophils. Everywhere you look, you see neutrophils. So that scores a 2, okay? So we've got a 2 for ballooning degeneration and or Mallory-Denk bodies. We have no problem finding Mallory-Denk bodies, hence the score of 2. And we have no problem in finding neutrophils, hence the score of 2 for that. Look at these. I mean, these are this. You could take a photograph of this and put these into a textbook for Mallory-Denk bodies. I mean, just see if I can find them. Look at that. Look at those. Beautiful. Okay. So classic Mallory-Denk bodies. Ballooning degeneration, not there. It's absent. And why is it absent? Because there's no steatosis. So, you know, that would be expected. So now let's look at the fibrous score. And when we look at the fibrous score, and we have a look at the mass on trichrome, you can see that we've got these broad bands of fibrous tissue. Look at that there. Okay, broad bands there, broad bands there. So this would be a score 4, and because they're broad bands of fibrous connective tissue, it would be a 4C. So we go back then to our diagram. Okay, and there at the bottom of your screen, well, when my pointer disappears, not sure if can you see the bottom of the screen below?
We can see the 4C.
Okay, can you see 4C? Because
Yes.
I can't. It's obscured. It's obscured by the options. But you can see at the bottom of the screen there, those broad bands of fibrous connective tissue, Chris, that you were alluding to, that would make this a 4C. So that's irreversible.
Yeah.
And as far as the prognosis is concerned, this particular patient, in fact, died a week or 2 after the biopsy. I can't recall if there was, I think there was steatosis. Sorry, not steatosis. I think there was cholestasis as well, intracanalicular cholestasis in this biopsy. Not to worry, though. I think from all points of view, he actually had poor prognostic parameters. Over to you, Bilal. That's the end.
That's fantastic, Prof. And I think that's pretty good timing as well. We're 5:29. There's one or two questions on the chat. If you guys would indulge, Mzamo Mbele is asking, often the clinical conundrum of a patient with decompensated ASH cirrhosis versus one with severe alcoholic hepatitis on the background of alcohol-related liver disease. MADRIs may be non-contributory. What are specific signs on liver biopsy that would indicate active alcoholic hepatitis? So my feeling there is that this SALVE criteria lends us towards that process, and you've got the activity grading with, I think, specifically the presence of neutrophils being a giveaway that you're looking at an active alcohol-associated hepatitis as opposed to a pure decompensatory episode.
Yeah, sure, Bilal.
Prof?
Hi, Mzamo. Yeah, I would agree with that. So I think neutrophils are a good indicator of activity. I don't think you can rely on Mallory-Denk bodies. We've seen Mallory-Denk bodies in our transplant patients who we're fairly convinced who are not actively drinking. Steatosis, you can't use either. But neutrophils, we've seen one or two patients who we have suspected have carried on drinking. But neutrophils, I think, are the indicator of continued consumption.
Great. And then Janet's asking, in the presence of multifactorial fatty liver disease, ASH-NASH, which scoring system would you recommend, or would you include both in the pathology report?
Janet, that's a difficult question. I think if you know the patient is, you see, we are lucky in that we no longer, we don't have to use the steatosis to grade the alcohol. So you could certainly give an alcohol score. And certainly if I'm faced with steatosis and I know that there is an alcohol component, if they're neutrophils, then I look and see if the steatosis is either lymphocyte driven or neutrophil driven. If it's lymphocyte driven, then I tend to lean towards a NASH. If it's neutrophil driven, then I would lean to alcohol. And also the other thing is to look for the chicken wire fibrosis, which is more a feature of alcohol than NASH. And then, of course, you've also got to look for the liver function tests and look for that AST, ALT reversal. And then also other things, and that's why the lab investigations are so important. IgA levels, gamma GT, macrocytosis, all those sort of things. And together you kind of, I mean, certainly from my point of view, I build up a picture. And in fact, as I was saying to Sipho, I'm not sure if he's on the meeting the other day, often by the time you've got the history and the lab investigations, you know what the answer is going to be in the liver biopsy.
Yeah, what I was actually going to even point out was that I think this is where your multidisciplinary team meeting really comes in, and where the clinician is able to give the further input in terms of what they've managed to pick up on history and clinical exam, and help with that differentiation. I know Prof often discusses cases before putting a report out in order to get our opinion as the clinicians. Yeah, I think that's important, working as a team.
Absolutely. You can't do it without. You can't do it without. And and then Janet, just to carry on, I think that the other thing that is important with that is to really describe what you're seeing, because ultimately, irrespective of the cause, the effect of that cause or cause on the ultimately the effect of those causes on the liver, even if they're multifactorial, is what's going to decide on the patient's prognosis. And then my last plea, just to remember drugs. I haven't mentioned drugs. Okay, if you see neutrophils, never ever forget to ask about the drug history, particularly the cardiotropic drugs.
Yeah, we've had quite prominent individuals looking at amiodarone which can most certainly give those Mallory-Denk bodies as well. So that's definitely one. Omelade Batiko is asking, either the fatty liver disease is due to ASH or NASH. Not necessarily always. You do get BASH, or both alcohol and non-alcohol associated fatty liver disease, and I think that's why Prof had that third case in the discussion, where it probably was more NASH, but she certainly did have further ASH. And I think in terms of treatment, it's still your lifestyle changes for these patients: cessation of alcohol, and looking at weight loss and lifestyle modification for the NASH. So yes, it would just encouraging the further lifestyle changes is important. It is 5 minutes over. Chris, any last comments?
No, excellent. Thank you very much. I'll write to Massimo, and I think we can have a follow-up lecture, Martin. Thank you very much for introducing this excellent topic.
Pleasure,
Yeah,
Chris.
absolutely.
I
think, yeah, no, Prof, that was really brilliant. Thank you so much for that presentation. And the SALVE consortium is still relatively novel. I do think it's important to come up with consensus guidelines and documents in order for us to have consistency across reports and practicing in terms of standards of care, and looking at novel therapies for these sorts of patients. It leaves me to pass on thank yous to the iEcho University of New Mexico and iEcho India team. A reminder to everyone that these recordings are available on the Gastro Foundation website. Thank you, of course, to the Gastro Foundation, Professor Cassinides and his team that do such a fantastic job at keeping medical education going. A big thank you to the sponsors, and thank you to everyone for joining us. Hope you all have a great rest of your Wednesday.
Thanks, Bilal. Thanks, Martin.
Thanks, everyone.
Cheers all.
Pleasure. Thanks. Bye.
Bye-bye.